Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcasts, Spotify, Google Podcast, Stitcher Radio, or on your favorite podcasting app. One of the scariest parts of the COVID-19 pandemic was continuing to prescribe immunosuppressive drugs in the midst of a novel infectious agent. At the beginning of the pandemic, we didn't know exactly whether people on immunosuppression would be at higher risk of developing COVID or of having more severe disease should they become infected, or being hospitalized or even dying. The data from China and Europe didn't show an obvious increased risk of harm in people continuing their immunosuppression, but there was still a lot we didn't know. Fortunately, 2 years into this pandemic, we now have answers to many of those questions. With us today is Dr. Alfred Kim to discuss B-cell depleting therapies such as rituximab and how patients on these drugs may be more susceptible to poor outcomes from COVID-19. He takes us back to the beginning of the pandemic, how he and his patients initially managed their rituximab infusions, how and why people on this drug may be at increased risk of severe disease, the importance of vaccinations, and why they may not work for this patient population. Fortunately, he also has important information about how to mitigate the risk of COVID-19 among people taking B-cell depleting therapies, now that there are new therapies for COVID-19 pre-exposure prophylaxis. For those of you that don't know Dr. Kim, he's assistant professor of medicine and assistant professor of pathology and immunology at Washington University School of Medicine in St. Louis, and he works as an adult rheumatologist at Barnes-Jewish Hospital. Dr. Kim founded and currently directs the Washington University's Lupus Clinic, engaging in both clinical care of patients with lupus and heading a large research program focused on clinical and translational projects related to lupus. More recently, he also started the COVID-19 vaccine responses in patients with autoimmune diseases, or the Covaripad study, which seeks to elucidate the strength, quality, durability, evolution, and safety of COVID-19 vaccine responses in patients who take immunosuppressives for their autoimmune disease. Hope you enjoyed the show. Al, welcome to the show.
Thank you so much, Jonathan, for the invite. Great to be here.
So you're a B-cell guy, right?
Yeah, I kind of grew up as a B-cell person. I've diversified also, but definitely that was my first love research-wise.
How did you get first interested in the B-cell?
So what's interesting is when I was a PhD student, I was actually mostly interested in T cells, CD8 positive T cells, and how they get activated after vaccination, actually. But when I got to Wash U for my residency and then eventually my rheumatology fellowship, when I started the fellowship, I started using a lot more immunosuppressives. And one of the things that was very confusing to me was, why does B-cell depletion therapies work when they don't really touch antibody levels that much? And that messed up my mind in terms of trying to understand these type of therapies. So it actually ended up being a postdoctoral project that I did in the lab of Andre Shaw here at Wash U, where I started examining antibody-independent effects of B cells and its ability to potentially drive tissue injury, looking specifically in the kidney.
Awesome. So what sort of insights do you have into B cells that maybe other people don't know?
Yeah, so I think there are a lot of functions that B cells do that are separate from its ability to differentiate into antibody-producing cells. I was really focused on the type of cytokines that they could secrete. There was work done before showing that B cells could actually essentially polarize into B cells that are more Th1-y. In other words, they secrete gamma interferon when stimulated, or they actually could polarize to secrete more atopic cytokines like IL-4, 5, and 13. They're more Th2-y. And so, our work showed that actually if you had what's called B effector 2 or Th2 skewed B cells, you activated them in the kidney, this could actually drive glomerular injury and proteinuria in mice. And we found similar signals in actually patients with minimal change disease, which is the most common cause of nephrotic syndrome in children. And what's interesting there too is a common trigger for these kids for nephrotic syndrome, minimal change disease flare, happens to be an atopic flare beforehand.
No kidding.
Yeah, so that entire story was really, that really got me interested in B cells. But obviously B cells function to activate T cells, they're antigen-presenting cells, and they also are really important in developing these ectopic lymphoid follicles in chronically inflamed tissues. T cells and B cells kind of get recruited there, almost trying to start like a germinal center reaction or even like a lymph node type of architecture. It can't do it because the stroma is not the right type of stroma compared to a lymph node. But nevertheless, these type of structures certainly exist in chronically inflamed synovium and RA, in the kidney and lupus nephritis, meninges and multiple sclerosis.
Wow.
Yeah, and again, I think we don't have a clear understanding of what these structures are exactly doing to contribute to disease. But yeah, these B cells do quite a bit more than our canonical, make antibodies downstream.
Yeah, fascinating. So let me take you back to March of 2020, if you can recall those dark days. At the time, I remember we've been hearing about this new infection starting in China, then taking over Europe, and it seemed that it was going to take over the world. What were you thinking with your understanding of sort of the immune system? What were you thinking about the impact of this disease would have on people with chronic inflammatory diseases or, autoimmune conditions such as RA and lupus and all the other diseases that we treat?
That's a really interesting question, because I think when COVID-19 first became newsworthy, I had no expectations of what was going to happen, yet somehow we dramatically underestimated the impact on the immunosuppressed. Obviously, the incredible work that the COVID-19 Global Rheumatology Alliance has done, and we've been both, very fortunate to be able to be some players in this very interesting team. It really showed very early on, based off the registry data, that people, particularly B-cell depleted people, were at high risk of converting from more mild type COVID to COVID requiring hospitalization or even worse. I think soon later on, like late spring, early summer, it was pretty clear that not only the presence of type 1 interferons, which are antiviral cytokines, were critical in controlling that transition or the progression of COVID-19 to something more severe, but also Akiko Iwasaki at Yale also showed that the timing of when you started generating antibodies was also critical. The later you generate antibodies, the more likely you were going to progress to severe COVID. So again, both of those ended up being the kind of the core correlates of protection immune-wise to be able to limit the severity of COVID-19. And so I think as those data were published, then I think then everything started to really click together in the summer of 2020, with the epidemiology data coming out and then some of the wonderful translational work that was done in the labs. So at that point, then I think we all knew that our patient base was at significant threat because of COVID-19.
Yeah, it was really interesting exploring patient sentiment at around that same time, especially, with the continuation of immunosuppression, right? Mm-hmm. It was thought that maybe some of the medicines that patients were taking would make them at increased risk of either, developing COVID or developing severe outcomes, but we didn't really know which ones. And, at the same time, we were concerned that if patients stopped their immunosuppression, their underlying disease would flare, and that's probably also not very good, in the setting of infection. So what did we learn in specific about specific immunosuppressive drugs and their effect on, developing COVID or severe COVID outcomes?
Right. So I think, again, a lot of work done by the COVID-19 GRA and also additional work from Jeff Sparks and Zach Wallace and other work done in EULAR and in Europe. I think it was pretty clear that probably the biggest threat were going to be these B-cell depleting therapies for RA, lupus, MS. I think the other aspect here was this increased disease activity / prednisone utilization. Obviously, those two are intrinsically linked to one another and it's statistically difficult to uncouple. So that was another thing. I think JAK inhibitors were also a signal. And that kind of makes sense largely because of the ability for it to attenuate interferon signaling. And we just talked about how interferons are critical in delaying the progression. And then I think the other aspects that were really bizarre were sulfasalazine was also a signal. And I still can't explain why that signal exists. I don't really have a good mechanistic answer.
By signal, you mean that, patients taking sulfasalazine may be also at increased risk of poor COVID outcome?
Yeah. And again, mechanistically, I know there's some people who've postulated why this is, but I can't wrap my head around it. It's too dense to understand that. But then on the other hand, I think there was interesting data with, like, say, TNF inhibitors.
Yeah.
Right? That it was protective. And of course, there is some data suggesting that in hospitalized patients, the use of TNF inhibitors now could also be used as a treatment for severe COVID.
That's right.
Yeah. So again, it's all really interesting. And again, this is a brilliant time to be a clinician dealing with immune dysfunction, whether it's rheumatology or whatnot, because essentially they're kind of like experiments. These are humans that have a certain immune pathway being knocked down for all intents and purposes. And we are seeing in real time how this impacts not only autoimmunity, but also infectious threats, vaccine responses. Again, it's really a really fascinating time to kind of see how all of these mesh together.
And it's so complex because, while you mentioned prednisone, that the use of prednisone may increase the risk of poor outcomes in people with COVID. At the same time, there were studies that showed that the use of dexamethasone emerged as one of the first treatments for COVID. And throughout, the last couple of years, many of our anti-inflammatory drugs and cytokine inhibitors were also used as part of the treatment for severe COVID-19. So how do you account for that? Does it matter when you expose the patients to these drugs that may have either a benefit or a risk?
Yeah, this was super confusing when it first came out. But I think right now what's pretty clear is that early COVID infection, you really need a robust immune response to try to control viral load, eliminate virus, generate adequate immune responses. But once COVID-19 essentially escapes out of that initial period, for those people that end up having severe COVID, the immune response is clearly pathogenic here. And that's obviously the driving impetus of why immunosuppression is both a threat early on, but can be used as a treatment later on, because the immune system's response to and its relationship to self, our body, is different. Early on, it's protective. Later on, the immune system actually is hurting us. So that was a very difficult message to describe to lay people.
Yeah.
When you're talking to patients, you're talking to other, healthcare advocates, this was not something that was very probably well elucidated, described by us as a profession. It did lead to a lot of confusion.
Yeah. Once the message was out there that B-cell depleting therapies may place patients at increased risk of poor COVID outcomes, did you change your clinical practice in prescribing these drugs?
I did. So anyone who's worked with me clinically knows I love me some B-cell depletion.
As much as you love the B cells, you want to just kill them. Is that right?
Exactly. I use a lot of rituximab in my lupus patients. We have a predominantly Black population here in St. Louis, and it seems to work just wonderfully for the vast majority of them. And it seemed, quote unquote, safe. Of course, the most dangerous situations, not knowing what you don't know. And then I think what happened with COVID was it really exposed the substantial risk of an ambitious infectious agent such as SARS-CoV-2 and its ability to overwhelm someone who don't have B cells. So my thinking changed substantially. I am prescribing a lot less now.
Yeah, interesting.
But I think as a kind of a footnote to this is that a lot of our patients that are on Ritux and for lupus, they did not want to change despite the risk and understanding completely what the risk is. Because I think in lupus, every disease is different. But in lupus, I feel like sometimes it takes a long time to find a mix of medications or the medication that allows them to regain quality of life, put their disease in some sort of remission. And they are not willing to change that, right? Because they all of a sudden realize this could destabilize everything. So I was a little bit surprised initially, but it makes a lot of sense from when you think of it from their perspective, why they want to continue it.
Yeah, I remember when this data came out and some of the patients that I had been, routinely given rituximab every 6 months, I'm like, well, do you really need it every 6 months? Let's hold off 9 months, a year. And many of them did pretty well. And eventually, their disease flared up and we had to use it again. And then the vaccines came, right?
Yeah.
So what impact has vaccine had on this patient population, people on B-cell depleting therapies and other immunosuppressive drugs?
Yeah. I think we all knew from a substantial amount of work in the past that B-cell depleting therapies were a major threat to human immunity. And that totally makes sense. It's really obvious. But I think that when we started discussing these vaccines to our patients, a lot of our patients still got vaccinated in hope of they might be that one rare person or persons that is able to escape and mount responses. I think from substantial work globally, and I think I want to give a shout out not only to our colleagues at WashU, Michael Paley and Parikal Deepak, but also at UCSF, Mary Nakamura, Leanne Gensler for our Coveripat study, but also people like Julie Pak at Hopkins had a huge cohort that's contributed a ton of data, along with people like Laura Boekel in the Netherlands. Collectively, it is quite obvious that at the population level, almost everyone on a B-cell depleting therapy just don't respond to a vaccination, and in this case, mRNA vaccines, because most of us studied that. As soon as that narrative was crystal clear and we started disseminating that amongst our patients and the public, then all of a sudden there was substantial concern. I mean, on Twitter, it became massive threads of people trying to figure out, how do I mitigate this, right? Trying to take things into their own hands, which may have led to some people making some decisions that we wouldn't have necessarily advocated, trying to boost their immune system, right? Using whatever supplement they could find on the internet. And so again, I think the loss of control that our patients had, especially on B-cell depleting therapies, even though we had tools, they couldn't leverage them. So they ended up taking things in their own hands. And obviously it led to some behavior that was probably riskier than I would have liked to see from these patients.
So when you mentioned that patients on B-cell depleting therapies did not respond, do you mean that they did not create antibodies against the vaccine? And could you measure, because antibodies aren't the only way that vaccines are effective, right? There's other parts of the immune system like T cells that, may be as important or more important in viral immunity. Is there also data that part of the immune system is also impaired in these patients?
Yeah, I think that generally the antibodies aren't obviously the only things that you generate. A lot of people have been talking about, T cell responses. And I think what's interesting is in vaccinology, one of the holy grails has been trying to develop a vaccine where T cells are sufficient to be able to generate protective immunity. No doubt they are required, especially follicular helper T cells and germinal center responses where antibody and B cell responses are optimized and enriched. The follicular helper T cells are absolutely required for that. And it's actually, as another footnote, it's an interesting target in autoimmunity right now. But, clearly the T cells can be generated. There's a really nice paper by actually a rheumatology fellow at Penn, Socrates, I'm going to screw up his last name, Postolidis. I screwed that up. But he's also a postdoc in John Ware's lab, big immunology lab at Penn. So he actually had a paper in Nature Medicine last year where they looked at circulating T cell pools in patients with multiple sclerosis treated with B cell depleting agents. And I think what was interesting there is while antibody responses were substantially blunted in these people, the follicular helper T cell responses in the bloodstream seemed intact. So they were still able to generate these T cells. Now, having said that, Jose Scherer had published very early on that the T cell frequencies or the makeup of the T cells in the blood were a little bit altered. There was reductions in CD4 T cells or your helper T cells. But interestingly, there were actually increases in CD8 or cytotoxic T cells in B-cell depleted people. So I think this is another thing we never really thought about before. Obviously, this is all in the context of vaccination. But the role, what B cells are doing to contribute back to the immune system response and the subsequent immunity that you generate afterwards, is that what can we learn from that? That's a great question. But I think at the end of the day, it seems like the T cells are certainly being generated. They are definitely spike protein specific, which is obviously the immunogen in our vaccines. But yet at the same time, it's in terms of breakthrough infections, the B-cell depleted people are definitely at the highest risk. So it tells me that either the T cells that are there and they're not sufficient, or they could potentially be sufficient, but they may be dysfunctional, right? And I think this is still work that a lot of people are looking at trying to deconvolute.
And then the vaccines came out. We recommended it, for every patient with rheumatic disease, even those on B-cell depleting therapies, understanding that they may not respond well. And then there were recommendations of added doses for people with immunosuppression. In these patients with B-cell depleting therapies and other immunosuppressive drugs, was that the right approach? Did some of them actually mount an immune response when they got, the third dose or even the fourth dose of the vaccine?
Yeah, so I think a lot of this depends on when their last dose of B-cell depleting agent was. There is a loose, not rock hard, but loose association between the interim length between your last dose of, say, rituximab and then when you get vaccinated. The longer that period, the more likely you're apt to generate good humoral responses. And this largely correlates with the return of B cells. But there's data that was published maybe a couple months ago from the Norwegian Norvac cohort that basically took people who were B-cell depleted and had really poor responses after the second dose and gave them a third dose. And the vast majority of them still had very poor responses. Of those that did have good responses, they tend to be further out from the last B-cell depleting therapy. All right. And so again, you brought this up earlier, and I think this is actually a great point, is that while the FDA recommendation for dosing interval for rituximab in RA patients is every 6 months, that seems to not necessarily be true for all RA patients, and certainly not true for our lupus patients. We tend to dose every 12 to 18 months. It just seems like that's the right interval for them. And during that time, their B cells do appear to come back in that last half interval. I wonder, again, this is something that will require additional work, is trying to figure out, are we dosing rituximab because of return of B cells or because of return of clinical symptoms? And I don't follow the RA literature that much, but this is actually something I probably should take a look at, because if we're doing it and this decision was made in combination because of the B-cell return, maybe that's not the actual right metric we need to be looking at. And especially when you're looking at the totality of safety and the ability of vaccines to work, we could probably extend it out quite a bit more. And again, some people may require every 6 months, and those people are, again, at the highest threat, but not everyone's going to be like that, I anticipate.
So it sounds like, from what you mentioned, the length between the last dose of rituximab sort of plays a big role in, how likely you are to respond to vaccines. Maybe getting added doses, especially if you're further out from the initial dose, might help. Anything else that patients on B-cell depleting therapies can do to try to mitigate the risk of COVID infection?
Yeah, so this goes into now probably the biggest saving grace for our immunosuppressed patients, and that's Evishield, right? So just a reminder, Evishield is a combination of two monoclonal antibodies that were actually isolated from two patients that had convalesced from COVID-19. And so one antibody is tixagevimab, the other one's silgevimab. And they both have strong neutralizing potential, particularly silgevimab, against the numerous variants. Silgevimab actually still retains neutralizing activity against many of the Omicron subvariants. And I think the other really innovative thing about Evishield is the modifications to the FC portion allows the half-life to be tripled, anywhere between, from 4 weeks for a typical IgG, now up to almost 3 months. And so this allows for highly potent neutralizing antibodies to linger on for a much longer time in people that may not be able to generate those type of antibodies. And I think I'm reviewing a few papers now starting to show potential, differences in breakthrough infections. Obviously, I can't give specifics in people getting Evishield, but again, I think there's a lot of very interesting applications and the way we think about how do we mitigate those effects of having poor vaccine responses using things like pre-exposure prophylaxis, which has been used in HIV for a very long time. But now I think this is really showing that we could really protect our immunosuppressed and that, a lot of physicians need to be thinking about how do we get Evishield to our patients.
So who should get Evishield? Is it every patient who's immunosuppressed? Is it patients on B-cell depleting therapies?
Yes.
Who are you giving this drug to?
Yeah, so the FDA EUA for Evishield is incredibly broad, similar to the original guidance for getting an additional dose for vaccination. So essentially, anyone on an immunosuppressive agent. I would say that probably the only group that doesn't qualify are people on hydroxychloroquine monotherapy. And I believe potentially those on aprilimast monotherapy may not necessarily fall under the EUA, but everyone else is. People on methotrexate, sulfasalazine, all the way to biologics and, of course, JAK inhibitors. So the EUA is very, very broad. And I think, importantly, the EUA does not tell us to check antibody levels. And I think this is actually the right step. I don't check antibody levels because A, you're not necessarily checking neutralizing potential. And even of the assays that are out there that are specific for that RBD domain, which is going to be the domain that binds to the ACE2 protein, enabling infection of target cells, even those assays aren't necessarily describing neutralizing potential. They're just describing what is binding to the RBD. We presume it's going to be neutralizing. But with all of this being said, we still don't know what levels are protective, right? And that becomes an issue. And so, even if someone comes back with a positive result with antibody titer in the middle, I don't know what that necessarily means. And that's going to be probably a good chunk of our immunosuppressed patients. So having said all that, I think the FDA was very clever in making sure that this type of verbiage did not show up in the EUA. You just give it just because they are on some sort of immunosuppression. I mean, the number needed to harm is extremely high. I mean, it's just the side effects are extremely rare. I think we've probably given maybe over several thousand doses here at WashU.
Wow.
We've not had any issues, to my knowledge.
Yeah, I think from reading the literature, the maybe increased risk of like cardiovascular disease, right? In a very tiny percentage of patients. And otherwise, it seems to be like incredibly well tolerated.
Yeah, exactly, Jonathan. And then the cardiovascular signal was observed in people with prior cardiovascular events. So you can pick out these people, in terms of risk factors. And then that discussion does occur, but at the same time, it's still quite low.
Yep.
And the ability, though, to generate or to acquire protective immunity, through these antibodies is substantial.
Yeah. So you didn't answer my question, Al. Are you giving this drug to everybody? RA on methotrexate, lupus patient on MMF, a GPA patient on rituximab? Would you give all those three patients?
Yeah. Yes. At least I'm offering it. I think to our surprise, and we actually have had discussions with AstraZeneca about this, there are a lot of physicians that don't know Evishield even exists. And this is really striking to me because I think we are not doing a good job because COVID moves so fast, and the ability to keep up with the literature and guiding principles is really, really challenging. It's a lot of information. And I think this is going to be not only in terms of how do we respond to these type of pandemic threats, but also like how do we best communicate highly actionable information to providers that need to know about this, right? Our current system, it may be through email right now, but obviously I delete a lot of emails without really reading it, right? And so that's not the most effective way to do it. So I think that's kind of the next part of the equation.
Podcast. That may be an answer. This podcast, Al, it's what's going to do it. It's what's going to get physicians knowledgeable on this topic.
Right. So I am giving it, going back to the original question, I am giving it to everyone, although early on we had to be selective because the supply was so constrained, and it really actually enhanced a lot of disparities in the St. Louis area, and I'm pretty sure everywhere else. But now supplies are pretty good almost everywhere. So, it's just a matter of how each state is rolling out the administration of Evishield. Their healthcare provider should know the details and be able to direct them, the patients, to sites or places where the Evishield is being administered.
Yeah, we mentioned sort of the very, very small cardiovascular risk. Any other contraindications or people that you think, would not benefit or from this drug?
Yeah. So in terms of contraindications, so there's a lot of discussion about the timing of Evishield and boosting.
Oh, yeah.
I think the argument people are saying is that, if you get Evishield first, then you get boosted a couple of weeks later, there's a potential you could blunt responses. I don't fully understand the principle of that. I mean, IgG is one of the most abundant proteins in our body. I mean, we have grams worth in our body. And, with Evishield, you're getting administered 600 total milligrams of IgG. All right. I'm not sure if I buy that argument. Would I give both on the same day? I mean, potentially you could. I don't necessarily, and that would be interesting to get feedback, particularly on Twitter, about whether or not I'm wrong on this. But again, there's been some discussion about trying to keep the intervals between
spaced out,
which is fine. In that case, I'd get Evishield first because now you're protected for at least 6 months, right? And then you can get the booster later on. Actually, I just want to say something about the word protection. The protection that I mean here is directed mostly to having disease expand beyond the respiratory tract. Just as a reminder, Evishield is IgG. The mucosal surfaces have very low IgG, and only 1% maybe of systemic IgG gets into mucosal surfaces. We obviously have a different antibody there, IgA. And so as a result, the Evishield doesn't necessarily prevent infection by itself. You can still get infected into the respiratory mucosa with Omicron, particularly the upper respiratory mucosa. And Evishield won't necessarily stop that. But what it will do is then limit the infection to that area. Because if the virus tries to escape and become systemic, there's so much IgG there, it just neutralizes and gets rid of the virus. So in terms of when you have that informed consent discussion with the patient, we just need to make sure that the discussion is about having progression of disease being strongly limited with Evishield, but not necessarily acquisition of virus.
Such a great point, Al. Thank you for that. And you're absolutely right that it may not necessarily prevent infection, but certainly it prevent, any of the more systemic infection outside of the lungs and upper respiratory tract.
Right.
The other thing that, I think it's sort of in the instructions of how to give it is the spacing between the last COVID infection that you had and the dose of the Evishield. I'm guessing that the issue is that, at that time you have sort of antibodies, self-antibodies against the virus, and maybe the response of the Evishield would be blunted? Yeah,
so again, that kind of falls under the same hat. I think there's a lot of, I don't necessarily buy that either, because unless the administration of antibodies somehow blunts the intrinsic ability for us to maturate B-cell responses and make high-quality antibodies ourselves, I'm not aware of those data. So, again, these, I think, are provisions put in more out of the abundance of caution tab more than anything else. But again, I would love to maybe be wrong about this and stimulate discussion, amongst the community, because again, to me, I'm not 100% sure I buy that.
How about antivirals for people that, maybe did or did not get Evishield? They're on rituximab or TNF inhibitors and they develop COVID-19. Anything that we can do for them?
Yeah, so Paxlovid, right? What an interesting drug. I mean, it has so many drug-drug interactions that fortunately you only need to take it for 5 days. So some of these medications you can hold, and I believe it's the CDC has a really good website that describes what type of medications you really have to be cautious for, and those medications where there are potential interactions, but it seems like it's safe to co-administer, including drugs like prednisone. I do think that it does help quite a bit, although the 5 days may be too short for some of the immunosuppressed, where, Len Calabrese has been monitoring on Twitter kind of this, the Paxlovid rebound effect. I first learned about it through him.
I've heard of that.
This is essentially where as soon as you stop Paxlovid, your symptoms come back. from COVID, and this correlates with increasing viral titers or viral loads.
So you may be more infectious, is that right?
Yeah, afterwards, like you've suppressed the replication of the virus, but you haven't gotten rid of it. So when you stop the Paxlovid, all of a sudden that break comes off, and then the virus can now thrive again. Now, this really depends on the ability of that person to generate, again, a recall response from prior memory responses to be able to get rid of the virus. But for the immunosuppressed, if they're on, say, B-cell depleting therapies, their responses are going to be blunted already. So potentially there's a theoretical risk that if you just do 5 days, they're going to rebound again, but they're going to have a more protracted course of COVID-19. And this is where getting a longer course of Paxlovid may be needed for these type of people. And that's purely speculation on my part, but I think that probably makes sense.
Is that something you're doing, or can it even be done? Yeah.
Not yet. We have had some people that have had repeat courses of the 5 days. Again, we're just monitoring by symptom return, and if they have symptoms more than a couple of days afterwards. Because the issue here is when you also suppress viral replication, now you have reduced antigen load. And so you're actually not going to stimulate the immune system as robustly as if you had full infection, right? It's going to be interesting to see at the end of the day what the right thing to do is, right? Because, with this reduced antigen load, because you're suppressing virus replication, is that actually a bad thing? But at the same time, it makes so much sense to be able to give antivirals when you have a virus infection. So yeah, we'll see how this all pans out at the end.
But, I think the development of Evusheld and Paxlovid has really made me feel a little bit better about giving immunosuppressive drugs to our patients. Initially, I had asked you whether your use of rituximab had changed at the beginning. So are you now a little bit more aggressive about starting people on rituximab or resuming rituximab in some of your patients because of these new developments?
Yeah, so I think I'm offering it more. Patients aren't necessarily taking the bait, though, after we have this discussion. They feel like there are other options, and they're not wrong. We do have other options. Like I said before, the people who have been on it, our legacy rituximab patients, they don't want to change, right, in our lupus patients. So they're the group that we're keeping very close eyes on. But yeah, in general, I've been prescribing it less, offering it a little bit more now. But at the same time, I don't think a lot of our patients see it as an a priori option for them anymore.
So stepping back, Al, what have you learned about either B cells or our use of vaccines, after the almost 2.5 years of this pandemic that, can maybe improve the way that we manage our patients going forward?
That's a great question, Jonathan. I think I'm so anchored in vaccine responses now. One of our collaborators is this extraordinary B-cell immunobiologist named Ali Alabedi, and he has done extraordinary work looking at B-cell responses, both in the blood, but also draining lymph node and bone marrow post-vaccine. He does these longitudinal studies. And one of the things that he has noticed with the mRNA vaccines is that the germinal center responses linger for months after vaccination, at least 7 months. And the reason why this is important is that these germinal center responses both contribute to affinity to its antigen, so there's some quality aspects to that. But also, part of the germinal center response is this somatic hypermutation phenomenon where basically you diversify the antibody repertoire, in this case to spike protein. And that's the reason why we get immunized with common variant, but at the same time we can fight off beta, delta.
Oh,
right?
Interesting.
Right? It's because this antibody diversification occurs. And then Omicron is an immune escape variant of SARS-CoV-2, but you get an additional jab. You reinitiate these GC responses. Now you diversify antibody responses where you can fight off Omicron. The question here is about if you happen to hold medicines for optimizing acute antibody responses, when you restart it, these GC responses are obviously still ongoing. What is the impact on that? Is that going to reduce antibody quality, right? And I think this is something that is kind of on the top of my mind is what's going to happen to these GC responses when you restart it? Like, does the quality change? Should we be even holding? Certainly with methotrexate, there's newer data showing that you hold methotrexate for a couple of weeks, you double your antibody responses acutely.
Is that data to COVID or?
COVID, yeah, to SARS-CoV-2 vaccination.
Yeah.
So it mimics exactly the Korean data for influenza responses. But again, they're going to be restarting it, and these germinal center responses are going to be ongoing and diversifying as the immunosuppression is, during the bulk of the time, you're immunosuppressed. All right.
Interesting.
I'm fascinated with where that's going to lead us in terms of our understanding of optimizing vaccine responses.
Right. So I think there's been, data about holding methotrexate during influenza vaccination. And I guess, the questions you're bringing up, is how important is that for immune response to COVID, influenza, or many of the other vaccines that patients should get who are immunosuppressed? That's a fantastic questions. What other questions remain unanswered or things you'd like to, further research going forward based on the experience over the last couple of years?
Yeah. So I think this holding medication thing is probably the thing I think about the most, right? And the impact. And of course, there's the NIAID, the ACV-01 trial, right? This is a clinical trial looking at additional dose responses, both in B-cell depleted people, but also people either on methotrexate or mycophenolate. And that part of the study, half of people are going to be holding meds and half the people are not going to be holding meds at the time of additional dose. So there's multiple sites. Obviously, the Harvard hospitals are part of this too. I think the idea about mucosal immunity is the next thing I think about. There are a lot of people developing vaccines that are intranasally delivered, but most of these are live attenuated, which we probably can't use for the immunosuppressed.
Right.
All right. So that's actually going to be the kind of the next holy grail for vaccines is to be able to generate mucosal immunity, IgA responses, but not having to require a live vector to do that. So that's kind of the other thing. And I think the third thing is going to be, the impact of immunosuppression on durability of antibody responses, right? I think there's clear data now that antibody titers, the kinetics of decay, slow, but they exist for immunocompetent people. There are some emerging data also now in immunosuppressed people showing, various differences. And we're looking at our own data to look at this too. It's not the same for all immunosuppressive classes of medications. But then that impact on protection is another question. So those kind of the big three I'm still struggling with because these are what our patients are asking too.
Fantastic. Fascinating questions that you bring up. One last question, Al. Do you think that the way research is conducted has changed or will continue to change going forward? As I've seen it, there's been so much collaboration, international collaboration during the COVID-19 pandemic. Do you expect that to continue going forward? Hopefully once this pandemic ends or sizzles down, what other changes do you envision for research going forward?
Yeah, no, that's a really interesting question. I have made so many friends and new colleagues through the COVID-19 Global Rheumatology Alliance. It's just my network has tripled in size. And I think the ability for global collaborations to occur has become much easier to do now. There's no doubt. On the other hand, though, is resource constraints, right? Our Covaripad study was under substantial threat early on. We just didn't really have enough money to do what we needed to do. We got very fortunate, and I have to give a lot of thanks to the Helmsley Charitable Trust. They gave us a fair amount of money to be able to get our project really through its full maturation stage. But most granting agencies aren't nimble enough to do that. Right. And I think this is something that needs to be thought of and addressed. How do we fund the projects that we think are going to be of the highest yield within weeks of idea conception? Right. So we only were able to capture maybe 14 or 15% of the participants that were interested in enrolling in our study. And I think we have over 400 people that we've enrolled. But it was just because we didn't have enough resources, financial resources, right? And so this is a bit of a loss, but nevertheless, I think, we still were able to do what we needed to do, at least at the core. It could have been a lot bigger and better. So I think this is, at least in the US, this is something that discussion needs to occur about that. Because again, it's the speed of response that's going to be critical, particularly because we can't tell people to wait to get a vaccine.
let me get my study funded first.
Yeah, okay. Wait 6 months. Right.
Let me see what my score is, and then I'll let you know whether or not to get vaccinated.
Right, exactly. Through our study or through your long range. Right? So anyway, I think that it was the universities and centers that already had some resources available to be able to get some of the early stuff going were able to do it, but we missed a lot of people still. I don't know what the right answer is, but there needs to be better ways to be able to get these type of things adequately funded.
Fantastic, Al. This has been a really enlightening and wonderful conversation. It's been great to catch up with you over the last 45 minutes or so. Thanks for all the work that you've done and that you continue to do. And I'm sure, your patients must be very excited to have you as their doctor and research. I really appreciate your time, Al.
I really appreciate the invite, and you do a great job, Jonathan, with this podcast. Kudos to you too.
All right. Thanks a lot.
Thank you.
Take care. Thank you all for listening, downloading, and subscribing to ACR On Air. Don't forget to rate our show and tell your friends about how great it is. Be sure to follow us on Facebook and Twitter at ACR Room for updates. As Al mentioned, please discuss Evusheld with your patients on immunosuppression. For any patients out there who are listening, ask your doctor whether you qualify to receive Evusheld for COVID-19 pre-exposure prophylaxis. And as always, please stay healthy.